Good morning. We have no disclosures. As you know, bile duct injury happens with a constant frequency. No matter the hospital, the experience of the surgeon, you always will find 1 to 3 cases in each 1,000 cholecystectomies. Although it is not known or reported the frequency in new modalities, many of them are converted to conventional laparoscopy, so that the frequency is going to be the same, 1 to 3 in 1,000 cases. It has been shown that when the primary surgeon repairs a duct, has worse results than when the patients are referred to interested centers. And you can find, according to the series, and not only the series, the type of injury. You know that although classified, each injury is unique. It's not the same results when you have, according to the Strasberg classification, an E1 injury with a dilated duct. Instead, you are dealing with a E4 or E5 injury with no dilated ducts. The result is another, you have another outcome. We started to do repairs at our hospital, and we have now 20 years of doing this. And we want to describe the evolution of the technical aspect of the reconstruction and compare the results in 3 periods. And these transitions are marked by important variations in technique that we began to do. Most of our patients are treated in the Nutrition Hospital, who is the main hospital, but some of them have been treated in other hospitals in the city and in the country. So we began to search for these primary endpoints: mortality, the use of transhepatic, transanastomotic stents, major and minor hepatic resections, postoperative cholangitis and anastomotic dysfunction, and reoperation, either surgical or radiological. We started to classify the injuries, and nowadays we use, for most of the cases, magnetic cholangioresonance. We can classify the injuries with this type of imagenological studies. At the beginning, we had a very small number of cases. You see in the first 10 years, 33. Then it began to grow, and we compared the groups 1 and 2 with group 3. And the statistical analysis was done by Fisher-Sachs test. This is the way that bile duct repair has grown in our hospital. We receive many cases from the whole country. I know that in the United States, for example, in a 300 million population, you do almost 1 million cholecystectomies in a year, so you have to expect about 2,000 injuries in the United States. In our country, with the third of population, and perhaps less indication because of money, many of the cases are not operated, so we have to expect almost 200 to 300 injuries in a year. And we receive most of them. And they have been growing, and now we are doing an average of 60 repairs in a year. We always do an hepatic angioinostomy. Know that some cases can be treated by the end-to-end anastomosis. Some very rare cases can be treated by the hepatoduodenostomy. But the operation of choice is an hepatic angioinostomy with a Roux-en-Y. We started to use, in all our cases, a transhepatic, transanastomotic stent. And we asked us in the early 2000s if we could use, in all cases, a stent. As you know, the Dr. Hopkins group and many groups use usually a transanastomotic stent placed for many months. We have done an evaluation of these cases, and we do not use routinely no more transhepatic stents. We always do high repair at the level of doing a very small resection of segments 4 and 5. This has the advantage of the HEPQUINO that you don't, if you use the standard HEPQUINO to descend the plate, you can injure the communicating artery between the left and right hepatic arteries. So a little bit higher, you can remove the segment 4 and 5 as much as you need. Sometimes it's very small wedge, sometimes it's a larger wedge. So to low down the plate and do another nice anastomosis, wide, tension-free, where the unal limb places well. And what we call the bile duct growing factor, that's is really a lateral anastomosis. It's an anterior cut of the duct from the confluence till the round ligament. So when we found the artery of the segment 4, we stopped there, and we can open that. This is how we do it. We do it with everted knots, separated stitches, 5-fold, absorbable monofilament sutures. Here is how it looks. It's a transversal section. The anastomosis is done, and where the arrow is the partial segment 4 resection, so that the limb, unal limb, goes there and comfortable without tension, and that the segment 4 doesn't make compression after releasing the retractors. As I told you, we started to use, in all our cases, at the very beginning, transhepatic transanastomotic stents. And we also used to place these inverted T-tubes. And then we began to analyze what if we needed, in all cases, a stent. And we use selectively now the stents. Only 1 in each 20 cases we use a stent, because we feel that if you can do a high-quality biliary anastomosis, it's wide, tension-free in non-ischemic ducts, you can have good results, and you don't need another intervention. We're analyzing, comparing the groups of patients with or without a stent, and we are coming to the conclusion that they have a better quality of life without the stent, and the need of reintervention is lowering with this type of techniques. If you always do a high repair, you will always find healthy, non-ischemic ducts that in the anastomosis will work well. That's the modification of the HEPQUINO, and also from Dr. Monteiro from Brazil. You can get a wide anastomosis even for non-dilated ducts. And there's a very nice, we do it as large as we can. In some instances, 1 inch, including from the type of injury. We leave, Dr. Strasberg in his paper published, he leaves the stumps, the stump with the scar there, and begins to do the anastomosis above the scar. We remove the scar and we open the duct, as you see there, and we do the anastomosis with everted single stitches knots. Segment 4 and 5 resection is simple, has a very low morbidity. The major thing is to descend the hilar plate. You can view, in all the cases, the anterior-posterior view of the confluence. You can do an anterior dissection of the ducts without injuring the circulation. You can get a wide and tension-free anastomosis and comfortable fit of the unal limb. This is how the groups where we compared, and you will notice male-female ratio remains the same. Still in Mexico, we have a lot of open cholecystectomies, and perhaps with the same incidence of injuries, but we receive, later has been changing more. At the beginning, in laparoscopic was 18% compared to, compared to the open approach. And many of our cases we receive had a previous repair. The patients that have an attempt of repair elsewhere, and they come to us, and many of them have, even, as you can see, some cases with 3 or more attempts of repair. We are doing, in almost all cases, I will say to 70%, perhaps 80% of the cases, a partial segment and far resection, and we are not using anymore transhepatic anastomotic stents. We do not do hepatectomy and repair only for difficult cases in which right hepatic artery is injured and the duct is not possible to rehabilitate. We have seen some cases with cholangitis abscesses secondary to the injury of the artery, so there is no work to repair the duct, the right duct. And we do hepatectomies in almost 3% of our cases. As you can see there, the frequency of postoperative cholangitis has descended in a significant fashion. Stenosis of anastomosis has also been better, and fistula and biloma have remained in the same, almost in the same proportion. Reparation, it depends, as I said, on the type of injury. If you had an E1 injury, it's easier to deal with than an E4 injury according to the Strasberg classification. But in some cases you need a surgical or a radiological operation. And the operative mortality has also been lower because of the selection of patients. At the beginning we began to do the operation when the patient was sick, very sick, with multi-organ failure. Nowadays we put in these cases where there are we do a limited operation to drain abscesses or bilomas and the percutaneous approach to drain the bile, and then doing the repair electively in this case. The conclusion, even high volume centers have a learning curve for repairs. Higher case volume, there are better outcomes. Refinement in reconstruction techniques I have shown have better results, decreasing the frequency of cholangitis and stomatic strictures and reparation, and always you need a multidisciplinary approach and adequate timing for repair. Thank you very much.
It's Rob Glasgow from Salt Lake City. Dr. Mercado, it's a privilege for us in the audience to have a chance to listen to you reflect on a 20-year experience with this ongoing and unfortunate, perplexing problem that all of us still continue to face. In looking at your data, there's a couple of observations that are pretty dramatic. The first is your pretty significant increase in volume over these period of times. The second is a dramatic decrease in the rate of recurrent stricture cholangitis and need for reoperation. With regard to the latter, you allude to your technical improvements, doing an anterior anastomosis, staying up high, and so on. I was hoping maybe you can reflect a little bit on what you've learned of the timing of repair. Several members of the audience, including a couple of our moderators, have written papers on trying to define appropriate timing. In patients who've had early injuries, what is early and what patients need to be treated late? And that might be a long, we may not have time to hear all of that, but maybe a chance to reflect on what you've learned briefly about the timing. And the other thing that's still dramatic in your data is half of the patients still have had a prior attempt at repair. We've also learned, and your data clearly shows, that the outcome for repair is better at high volume experienced centers in Mexico as well as in the States and other countries. But why are patients still undergoing an attempt at repair that obviously results in failure? And that's maybe a rhetorical question. You know, are we not educating our trainees? We're not educating them how to necessarily fix these injuries, but maybe we should be doing a better job at educating them how to prevent making the problem worse, because I don't think that we're doing a good job with that here in the States. So thank you very much.
Thank you for your comments. Yes, indeed. I begin with the last question. Most of the surgeons have fear about doing the injury, and so they don't send the patient for repair, and they try to do repair, and they argue to the patient and the family, you had a Medici syndrome, the bile duct was included in the, and they don't give the real truth what happens. And so the surgeon has heard about doing a repair, and then they try to do a repair, and most of them try to do the repair. I know that in the United States, a lot of people refer the cases, but in our country, still the primary surgeon wants to do the repairs. And the second question was about the timing. Really, early versus late repair is difficult to assess. What we do is some people, some authors wait a long time to stabilize the injury, so the ischemia of the ducts will resolve in 2 to 3 months. If you use the intrahepatic approach, you don't have to wait. So we only wait if the patient has real sepsis or multi-organic failure. If not, we proceed with the repair as from the very first beginning. We don't wait a lot of time.
Yes, sir. Please identify yourself.
Kevin Charpentier from Providence. Can you tell us what percentage of injuries in your experience had a concomitant vascular injury?
Well, you know that paper from Scott Helton and Professor Strasberg. In our cases, we were going to we present that in Argentina. 22% have a right hepatic arterial injury. But the microvascular injury is so important as a major arterial injury. If the duct is dissected and electropulverated and all the lateral arteries are taken away, the result is so bad as if the right hepatic arterial injury. In our experience, the right hepatic arterial injury we found in 22% of the cases.
Dr. Gomez.
Congratulations, Miguel, for your work. Only a question. Why, I want to know your opinion, why is increasing the number during the years of the laparoscopic injuries in your country? Do you think the learning curve is not applying? What's the reason? Must be down. It's up.
Yeah, well, our hospital is a referral center, a major referral center. I know that some other cities in the country do the repairs. So the frequency in our hospital from injuries to laparoscopy is only 0.1 to 2.3%. But I think that happens. Many surgeons have access to a laparoscope, and still they are not well trained, and they don't convert. They don't convert to an open case because of the people feels that if it's a failure if you do not do with the laparoscope, and they try to prevent the operation. Thank you, Nestor.
Dr. De Santibanez.
Miguel, congratulations with your huge experience. I think that maybe one of the most difficult cases are that separate right and left side. So how you deal with the anastomosis in the right side, because it goes deep, the direction of the anterior and posterior branches of the right bile duct go inside the liver. It's totally different the direction of the left that is horizontal and you can find it outside. How do you deal with it? Is enough or the resection of segment 4 and 5 that you apply so often is enough to perform a good anastomosis if you have to anastomose separately the right or the left, because you are not applying too many to the liver resection? That can be one of the options.
Yeah, thank you. Thank you, Eduardo. Dealing with E4 injuries, these separated ducts, we have recently sent a paper that was rejected. We sent the paper analyzing 45 cases of separated ducts. We want to do always, when possible, a neoconfluence. After removing the segment 4 and 5, we try to do a neoconfluence. You're right. In some instances, I cannot find, for example, the right posterior duct, and they are very difficult to deal with, these accessory ducts, and in some we leave them waiting for that these two segments develop secondary biliary cirrhosis and then atrophy. Some cases develop cholangitis and abscesses, and we have to remove the posterior part of the right lobe, or including the whole right lobe. That's in almost 3 to 4% of our cases. As you said, it's more difficult to do an anastomosis of the isolated right duct. It's more difficult than in a liver-related donor. You're very right. The duct is deep in the parenchyma, has no Wallerian sheath, so it's very difficult to do an anastomosis there. But in these cases, we do the anastomosis to the left duct, and then we include it in some type of portoenterostomy, the right duct. And the future of this duct, that is not an epithelium to mucosa anastomosis, is perhaps they close. They close with the time, and they become cirrhotic, and the complex of hypertrophy of the remaining liver occurs. It's very difficult, but you are right. These are very, very difficult cases. In some cases, we use only a portoenterostomy, like a Kasai procedure, the odd operation for this new disease, as Professor Pickelman says.
Miguel, I think we don't have the next paper, so I think we have time. Is Dr. Lee here? Is that correct, or not here? Yeah. So if I read your slides correct, the majority of these cases have open cholecystectomy.
Yeah.
So, I mean, and it looked like maybe 2/3 of them were still open, maybe 1/3 laparoscopic. Is that a reflection of what is happening with cholecystectomy in Mexico now, or is it just the most difficult are open and then they get injured?
I don't have how many of the cholecystectomy are still done open in Mexico. I have data talking in Germany, for example, still 20% of anastomosis are done open because there are no access to laparoscopes and everything.
In the U.S., it's 10%.
But I always look, when I receive the patient, I always look for the scars, the umbilical scar. And some of them have another type of incision, and they say that they started open, and because, as I always say, like in the airlines, they are frequent flyers, and surgeons are frequent liars in these things. They always lie. They say, no, it was not started laparoscopically, it was an only incision, it was a Merisi syndrome, it was and it's very difficult to obtain data about that. But I think that the open approach is still a major.
How about in Argentina? What % are open in lab?
Sorry, I was thinking of my question, not in I'm sorry.
But I mean, seriously, aren't the majority in Argentina done laparoscopically now?
No. The majority of the procedure, 98% of the procedure are laparoscopic in Argentina.
In Argentina,
Yeah.
but not in Mexico.
Yeah, I know.
Okay.
My question is regarding arterial injury. So in my country, we have the need in our hospital to perform an angiography to all the patients that we receive, not only because of legal reason, because we have to demonstrate that we did not make the lesion, if not because of some medical reason. Are you doing angiography in all the patients that you receive? And if you demonstrate that the patient has a arterial lesion, does this lesion condition, put any condition to the treatment that you are going to apply to this patient?
Yes, this is a very good question. We do not do a routine angiography. I started to look for the right hepatic injuries for 3 or 4 years ago, and some cases we do an angioresonance and we look for that, but we do not do routinary an angiography. And it's almost, I have seen fresh injuries with the two artery that is also not injury but also has a loss of substance. And they are very, very difficult to repair. And therefore in Germany has some cases that put a venous graft, and some people, Professor Sakis, uses the gastrocolinear artery and we have found that most of the cases we remove the clips or the knot in the right hepatic, in the distal artery, and they have retrograde flow. Not so heavy with a lot of pressure, but they have retrograde. So you can imagine that it will restore in the time. What we have found, if you do the anastomosis at the intrahepatic level, at the confluence level, doesn't matter if the right hepatic artery is injured. Some cases, you have the consequence, as Dr. Stewart described, the consequence of right hepatic injury where you have intrahepatic stenosis of the ducts, abscesses, hemobilia, and everything. And then we have to remove. But we do not do routinary angiographies.
Okay, we've used our time. That's excellent. Thank you very much. Thank you.